if you give drugs to affect the muscles, but if you have the same receptor somewhere else, you're also going to affect that receptor. You can inhibit upcoming signals, unless it's by shunting inhibition or by it's usually like opioid receptors, which are inhibitory, so upcoming signals from like pain won't get processed. And the other part of the gate control theory is if you have, let's say, because multiple different signals, different types of signals can come in. So if let's say you hurt your hand, if you rub your hand or like press on your hand, it will decrease the pain because those signals will overtake the nociceptor signals coming in.
Is that why we clutcher when we hit our hand?
When you hit your hand, yeah, you can like rub or put pressure on something. Yeah.
Right.
Let's get back to the somatosensory nervous system. What do you know about the control of arterial tone? Where is most of the resistance in the circulation?
In the area with the lowest cross-sectional area, with the highest resistance. So would it be in the arterioles?
Yes. And what controls the arterioles? What have we been discussing?
The sympathetic and parasympathetic nervous system.
Okay, and so how do you control blood pressure in this way?
You would control the volume of blood being released in these areas, or you would lower or increase the heart rate.
Yes, you could control heart rate as well, but how would you do it through changing the arterial diameter through the tone, the arterioles? Or dilating, what would constricting?
Constricting would increase the blood pressure, while dilating would lower it.
And which system does what?
What context would you use?
Which arm of the autonomic nervous system?
Oh. The sympathetic would constrict. The parasympathetic would dilate.
Yeah. So have you heard of something called orthostatic hypotension?
No.
If, let's say, you gave a drug to inhibit... Okay, sorry, I shouldn't have started with that. Do you know what happens when you stand up? How does all your blood from a lying position change under the influence of gravity? Where would the blood go?
It would pull to the lowest areas of the body.
Yeah, so the legs.
Yeah, and the hands as well?
It's mainly in the legs. So what would you do to increase... So what would happen to your blood pressure then?
It would lower. Constrict the artery.
And
increase the heart rate.
Yes.
Yeah, okay.
So what would you do what would happen if you, let's say, used an adrenergic antagonist at the alpha, I'll say even for alpha-1 receptors?
Inhibit?
Yeah, okay, so you're inhibiting the adrenergic receptors.
Yeah.
Okay. Well, what would you say would happen when you stand up and you have inhibited the adrenergic receptors?
Where are the adrenergic receptors acting again?
With the sympathetic nervous system. Where does the sympathetic nervous system act? To control blood pressure.
In the heart.
And
the arterioles.
Yes.
Yeah.
So what would happen if you had an adrenergic antagonist or an inhibitor of the adrenergic receptor and you stood up?
It was... Okay, so you're inhibiting the adrenergic receptor at the level of the heart and in the arterioles. So inhibiting adrenergic means you're inhibiting. So adrenergic was for adrenaline.
Yeah.
So you're preventing it from binding. So you are increasing, you are dilating the vessel as a result. This is why it was constricted.
So when you stand up and you dilate the vessel, what would happen?
Lowers the blood pressure.
Yeah, more blood would pool in the legs. And this is what is called orthostatic hypotension. Have you heard of that?
No.
Ortho is stand and static stasis. It's a Greek word, and it's a lowered blood pressure. Now, the field of developing. Have you heard of hypertension?
Yeah.
What is it?
High blood pressure.
Over chronically elevated high blood pressure over a long period of time.
Long period. Oh, in time.
Okay. So the treatment of hypertension, which is there's a form of called essential hypertension, which is the only real presenting symptom, is essential hypertension. The development of some of drugs to decrease the heart rate was a big field, and is what brought Pfizer in really as a what's it Pfizer? Anyway, it doesn't matter. I think Pfizer was to do with statins. Sorry, but so if you give a drug, so the first conceptual was to give a drug to block all the sympathetic nervous system receptors. How do you think that would affect the cardiovascular system, and what are you trying to do in hypertension?
Give a drug to affect the.
You're giving a drug for hypertension. What are you trying to do? You're trying to
dilate the blood vessel.
Yeah.
Yes,
that's one part of it. But what else are you trying to do also?
Reduce the heart rate.
Yeah. So in this way, you have the first generation of non-selective sympathetic antagonists. Well, not first generation. It just has sympathetic antagonists. But what they actually I lost my train of thought. Well, what I was really probing for there is there's a difference between the receptors in the heart and in the vessels. So the vasculature, you have alpha adrenergic receptors, and in the heart you have beta receptors. How do you think targeting non-selectively, so targeting both alpha and beta receptors, what do you think that would cause?
We're going to have both effects.
Yeah, so yes, we have both effects. But what do we notice by having both effects? What do we notice when you start blocking peripherally instead of dilating? What would happen when you stand up?
Low blood pressure.
Yeah, so you get orthostatic hypertension, right?
Hypotension.
Yeah, because you're blocking peripherally. So how can you, let's say, combat getting that orthostatic hypotension by blocking all the adrenergic receptors non-selectively? Instead of blocking alpha receptors and beta receptors, how do you think you could stop not getting the alpha receptor effects?
By blocking the beta.
Yeah, so that's why they invented beta blockers.
Oh.
And beta blockers act selectively on which organ? Yes, but actually they're not selectively, so they also act in the kidneys. That's another story. And yeah, so they act. Yes, the beta blockers will bind the SA node to inhibit beta receptors and decrease the heart rate. Blockage of alpha receptors and other sympathetic antagonists peripherally can cause orthostatic hypotension. Yeah. So thank you very much for listening. That was the end of our interview. Yeah. Thank you very much for Constantine for having a crack at that. This isn't easy stuff. Hopefully we were able to bring to you a little bit of the dynamic or a bit of the style of a Cambridge interview, similar to what I had as well when I was applying to Cambridge. Yeah, and it's really Cambridge, what they really want to see is an integration and trying to use what you know, and they're really trying to push you for you to see if you could use your baseline knowledge to think broader in a bigger context, in a context with application into kind of the stuff that you'll be studying when you come here for medical school, and things you'll tackle here. So they want to see that you're ready to learn, ready to think out loud, show them that you have the skills and capabilities of things like resilience, flexibility to work through such a tough situation, which eventually, at the end of the line, once you do your preclinical years, will become more trivial and more straightforward, and you'll be able to appreciate what your now lecturers would have been trying to do at your interview stage. So
Okay, yeah. Maybe in the actual interview, they might not go so specific with a lot of terminology. They might just try and test your thinking with simple things, and try and help you in a productive way towards the answer. It's not about judgment here; it's about learning. So
just to say that this is one video, a longer part series where we attempt different topics and different topics and different types of questions they could ask you, things you think about, things that integrate some of your biology knowledge to the broader medical field, physiology, pharmacology, pathology. So stay tuned. Make sure to like and subscribe, leave any comments if you guys have any questions for us to answer. Honestly, we have so much more information to share, so do get in touch if you want to know more, learn more, and please let us know anything else that we can do as well. So anything you guys want to hear or you want us to bring to you. Medical school applications can be very tough and interviews are very daunting, so
Alright.